All right, so next up we have section 15. This is going to be the common research designs used in epidemiology. So we're going to take all the kind of stuff we learned in the last section, apply it into how the designs of the studies are done in order to help find some of this information that we're interested in from an epidemiologic standpoint. So we'll look at different functions of research design. We're going to look at the different types of studies and some of their kind of the pros and cons of each of them as they compare to one another. And so we know that research is this process of answering a question that can be answered by appropriately collected data. So again, what is or was the frequency of a disease in a certain place at a certain time? We'll see that they can either be descriptive research that we're looking at. We'll also look at the research, whether it's going to be more quantitative or qualitative in that nature. So we'll talk more about in more details about that. But we do know that the research that we collect is really no better than the quality of data obtained. And so again, we'll talk about how things like, randomized controlled trials are always the gold standard for collecting data. We realize that's not always going to be possible, but research can be severely limited by the quality of data that we have. And so the rules that govern the process for collecting and arranging the data for analysis are going to be that research design that we're looking at. So, another question we might be trying to ask is what caused this disease? And so there's a kind of a difference between hypothesis generation, where this is the process of developing a list of possible candidates for a cause of disease and trying to obtain some initial evidence that supports one or more of the candidates. So trying to figure out, what are the possible causes of it? And then once you have a hypothesis generated, then you have to test it. And so we'll talk about the different study designs that lend themselves more towards hypothesis generation or more towards testing. Which one do you think is easier to do? Yeah, it's easier to generate ideas, and some of the data you'll look at is much easier to collect than actually testing the hypothesis. Usually a lot more costly and time consuming to test a hypothesis rigorously. And then we'll be able to make predictions from the hypotheses, and examining new data helps to determine if our predictions are correct. So, if you were able to generate a hypothesis and test it, and it's not supported, so say you're not able to find the difference you're looking for, and you have to accept the null hypothesis, what you do from there is either discard the hypothesis and start over. You can modify it and test it again, or take the same thing and test it all over again, say a new sample. Maybe increase your sample size, or whatever you have to do in order to try testing it in a new light to try to find the difference you're looking for. So some specific research designs are going to be appropriate for generation. Some are going to be better for testing. We're going to see the pros and cons of each one from that standpoint. And we'll see that basic functions of most of the epidemiological research out there is designed to either describe the pattern of health problems accurately, or they're going to be able to enable a fair, unbiased comparison to be made between a group with and without a risk factor or disease, and looking at preventative or therapeutic intervention. Right, so looking to see what kind of outcomes happen if you have a risk factor, or if we give you an intervention, what are the outcomes at that point. So good epidemiologic research design should perform the following functions. So it should be able to enable a comparison of a variable, so a disease frequency between two or more groups at one point in time. Okay. Some cases you're going to find that between one group, you'll do kind of a pre-post kind of analysis. So you're going to look at, say, an intervention or risk factor before and after, and looking at the outcomes in that sample. So you imagine if you're doing, say, like a t-test, would you use a paired or unpaired example if you're using a pre-post kind of design? I'm looking at the same people before and after an intervention. Yeah, it should be paired, right? So again, remember, keep those things in mind. Biostats will still pop up here and there. And then it should allow for the comparison to be quantified in absolute terms, as with things like risk, absolute risk, looking at rate differences, or should be able to look in relative terms. So we'll talk about relative risk, odds ratios. So again, whether you're just subtracting risk or rates from one another, or if you're actually looking at doing dividing one by the other to get relative risk, odd ratios, and things like that. And it will permit the investigator to determine when the risk factor in the disease occurred, to determine temporal sequence. This will also be a useful thing to show. And then they want to minimize biases, confounding, and other problems that would complicate interpretation of that data. So make it as less prone to bias as possible, so that you can actually take that data and do something with it. So depending on the design chosen, they're going to help with the development of hypotheses or testing it. Or you're going to see some designs are going to be better for both in certain circumstances. We'll talk about which ones those are. Cross-sectional surveys and ecological studies are going to be useful for developing hypotheses. That's really the main utility you're going to get out of those. Cohort studies and case control studies can be used to either develop hypotheses or to test them. Usually you're going to see the hypothesis development and hypothesis testing should be done on different data sets, right? You don't want to develop a hypothesis and then test it on the same amount of data because you're more likely to find a difference when one really isn't there. And then randomized clinical trials or field trials are going to be most effective for looking at the actual outcomes and new treatments or preventative measures, right? And so if you remember, which ones are going to be more prospective in nature? So do you think a randomized controlled trial would be prospective or retrospective? Yeah, it should be prospective, right? So it's going to be, we'll talk about the different study designs, but keep that in mind. Think about which ones of these are going to be retrospective, prospective, because that's going to make a difference on the type of data we're getting. So here's kind of a breakdown of some of the advantages and disadvantages. You can refer back to this as we go through these more in detail. This is just kind of summarizing the data we have here. So first thing we're going to do is to observational designs for generating hypotheses. These are going to be our cross-sectional studies and our ecological studies we're going to look at first. So a cross-sectional survey is going to be just a survey of a population at a single point in time. So in here, if we're going to be looking at, say, occurrence of a disease state, are we looking at prevalence or incidence? Should be prevalence, right? Because this is, say I'm looking at you guys and I'm trying to determine the outcome of, say, asthma. Who has asthma in this room? I would go through and survey each one of you guys. So at this particular point in time, I'm looking at how many people have asthma versus don't. So that would be prevalence, right? Incidence is going to be more for new occurrences as time goes forward. So if I took all you guys and I measured you for, say, the next 10 years who developed asthma, that would be incidence, right? So think about that. So you're doing these surveys. These are outcomes that have already occurred. It's going to be looking at prevalence. So good examples of this include things like interview surveys or mass screening programs. Interview surveys may be performed by, say, trained interviewers who are either going to people's homes or calling, sending out email surveys, things like that. Obviously, telephone surveys and email questionnaires are going to be the quickest, probably the easiest, but the big problem you have is non-responders. So again, if you get a telephone call asking you to participate in a survey, what are you going to say? No, I'm eating dinner, stop calling me. Yeah, whatever you have to say. My dad, he recently laid this one on me. He says that he gets really angry with him and says, like, how'd you find this number? I'm in the witness protection program. I have to go get a whole new identity. Hangs up. It's like, okay, you're definitely my dad. So again, you see that there's a big non-responder rate. So again, oftentimes greater than 50% are people, less than 50% are actually going to be responding to these surveys. And so one exception would be the U.S. Census. They are a little bit more aggressive with this, and so they're going to be definitely following up on non-responders pretty frequently. So cross-sectional surveys have the advantages of being very quick and easy to perform. They are useful for doing things like determining the prevalence of risk factors and the frequency of prevalent cases of some diseases for a defined population. So again, if you're looking at a specific population, say inner city kids, and looking at incidence or prevalence of say lead exposure, a certain lead level in those patients. That would be one way to potentially do it. Measuring current health status and planning for some health services, including setting priorities for disease control. So if you see that AIDS rates are starting to increase, like that may determine your priorities versus if some other disease state was becoming more prevalent. Major disadvantage of using these cross-sectional surveys is that the data about the exposure to risk factors in the presence or absence of diseases are collected simultaneously. So this is going to be able to, this is not going to allow us to make that temporal relationship or presume cause and effect. So again, if I just looked at the number of people in here who had, say, had asthma and then who had pets growing up, I can't really determine which one happened first just by doing a survey and getting yes or no answers to those questions, right? So because of that, cause and effect is really limited. This is why this is useful for generating hypotheses and not testing them necessarily. Another disadvantage is that a cross-sectional survey selects for longer lasting and more indolent diseases. And so this is going to be called this late look bias or this Niemann bias here. And essentially what we're seeing is that patients who are living longer with a disease or have more indolent cases or slower progressing, they're going to be sticking around for longer. So you're more likely to end up surveying them than someone who had a rapid progression of disease and say died or no longer had the disease afterwards, right? So that's one of the big kind of limitations of these cross-sectional studies is you're more likely to find those long-lasting cases than you are those really quick ones. So another thing you could call this is length bias in screening programs, which tend to find or select for these less aggressive cases because they live longer and are more likely to be available to be found at the screening. Repeated cross-sectional surveys can be done to determine changes in risk factors and the prevalence of disease frequency in populations over time. But again, it can't really tell us that nature of the association. Just because you see, risk factors increasing and the prevalence of disease increasing, you still cannot make that assumption of there being a causal relationship there based on the study design we're looking at. Data derived from these surveys can be examined for associations to generate hypotheses, but are not good for testing the effectiveness of the interventions. Because again, we're just getting kind of one point in time. We're not really seeing, able to determine that cause and effect. In a cross-sectional survey, investigators might find that a subject who indicated they had been immunized against a disease had fewer cases of the disease. And is this finding, was due to the fact that people who sought immunization were more concerned about their health and less likely to expose themselves to disease? So there can be some biases there. We have people who say are more concerned about the disease are going to be able to, do more to avoid it or to prevent it. So keep in mind some of these biases that can creep up in these type of surveys. Cross-sectional surveys are also of particular value for infectious disease epidemiology, so you see a lot of studies like this being done frequently, especially if they're looking at things like the prevalence of antibodies against specific infectious agents. So if you're analyzing either by age or other variables, it may help you to provide evidence about when and in whom infection has actually occurred. So a good example of this would be like a proof of a recent acute infection can be obtained by looking at 2 serum surveys separated by a short interval. So you're able to take 2 samples from patients at different times. You can look to see that there was a recent disease occurrence or not. So for instance, the first serum samples called the acute sera would be collected soon after symptoms of an infectious disease appear, and then you would take a second sample, say 10 to 28 days later, to get this convalescent sera. This gives you an idea of how antibody levels are going to be changing over time. And so a significant increase in the serum titer of an antibody to a particular infectious agent would be taking proof of as a recent infection. Another way we can do this as well is if you're looking at, if you can't do, say, 2 serum samples, you could do 1 and look at the levels of, say, IgG and IgM. So you guys, I'm sure, have gone through IgG and IgM, the difference between the two, right? So for instance, you can, by looking at the relative levels of one another, you can kind of assume how recent or long ago someone's been infected with a particular disease state. So say you have a high IgG titer without an IgM titer of antibody to a particular infectious agent, that may suggest that the infection occurred in the distant past, right? However, on the other hand, if you had a high IgM titer with low IgG, it may suggest a very current or very recent infection. And then if you had elevated IgM titer in the presence of high IgG, that would suggest that the infection occurred in the somewhat recent past. They may not actively have it any longer, but it at least occurred somewhat recently. So being able to look at the differences between those and interpret those levels may give you an idea of when the disease occurred. You can also have these ecological studies, and so these are basically cross-sectional studies that are relating to the frequency with which some characteristics, so say like smoking and some sort of outcome of interest like lung cancer occur in a specific geographic area. So you see this a lot, especially with like state Department of Health, things like that, looking at a city, a county, or a particular state. And so these are also going to be good for suggesting hypotheses, but they cannot be used to draw those causal relationships as well, because again, they're only looking at one point in time. They cannot establish that temporal relationship. So there's no information as to whether people who smoked are the same people who developed lung cancer. You're just looking at the prevalence of each within that population. And it's unknown whether that exposure or the beginning of lung cancer came first. So we don't know if they started smoking, then got cancer, they had cancer first, and then started smoking. You can't tell from this data because you're just getting one set of information. And there could be other explanations for the observed association. So a lot of times people can kind of take information that's being reported, especially in the news and things like that, and kind of run with it. And so they're unaware of kind of the weakness of the associations here that can be drawn, or this ecological fallacy that comes up. So say, for instance, you hear that there's high levels of both toxic pollution and cancer in northern New Jersey, so the toxin has to be causing the cancer, right? Not necessarily. We know that we cannot draw that conclusion strictly from looking at these ecological surveys. So a conclusion may or may not be correct. You need better data or better study design to determine that. So there are cases in which important hypotheses initially suggested by these cross-sectional ecologic studies were later proved to be correct by other types of studies. So say, for instance, we're looking at the rate of dental caries in children who were found to be higher in areas where they had low levels of natural fluoride in the water versus areas with high levels of fluoride. Right? So they were to do ecological survey and looked at the exposure to fluoride in the water versus the dental caries that the children were developing. And then subsequent research established that this association was definitely causal. They were able to test that hypothesis that they generated from the Ecological Survey, and then able to find that yes, this was true. And then now that's what kind of led to a lot of the fluoride being added to water. You can have longitudinal ecological studies. So these are going to be ongoing surveillance or frequent cross-sectional studies that are used to measure trends in disease rates over a period of years in a defined population. So you can compare trends in disease rates with other changes in society. So certainly things like wars, immigration, or the introduction of, say, a new vaccine or antibiotics can change these pretty rapidly. And so the epidemiologists are attempting to determine the impact of these changes on disease rates. So an example of this would be introduction of the IPV and the OPV, or the inactivated poliovirus, or the oral poliovirus, resulted in a precipitous decrease in the rate of poliomyelitis in the U.S. population. But we would end up seeing large numbers of people involved in the immunization program and the relatively slow rate of change of other factors in the population. Longitudinal studies can help us to determine the impact over a long period of time to see those changes in relation to those impacts we're instituting. So certainly confounding with other factors can distort the conclusions drawn from these ecological studies. So if the time is available, investigators should perform field studies, which we'll talk about a little bit later on, before pursuing, say, a new large-scale public health intervention. So you should really generate the hypothesis from these ecological studies, test it with a field trial, and then see what kind of differences you'll be making in the long run. So for instance, if you see that different rates of poliomyelitis are going up, you can look to see if there's a new vaccine implemented, and then based on that you do a field trial to see how the vaccine works, and then you can institute a new program for that in the kind of larger population. Another thing we can see here is another example of a longitudinal ecologic research. Was a study they were looking at malaria in the U.S. Population since 1930. And so you can see the impact that different points in history have on the rates of malaria based on things like wars and immigration occurring that can lead to certain spikes of it. So here, again, looking at from 1930 to 1995, basically you can see that people would relapse from overseas cases, maybe traveling to the U.S., and you see a pretty general decline. But then when you had a bunch of Korean War veterans come back, all of a sudden we had new cases of malaria popping up, and then continued to go down, and then we had Vietnam War vets come back, and then continue to go down. And just foreign immigration in general was leading to a spike. So again, you can kind of investigate these impacts over time using these longitudinal studies. So how about some observational designs for generating or testing hypotheses? This would be our case control and our cohort studies. So some important causal associations have been suggested by longitudinal ecologic studies. So again, you are suggesting these associations, but not truly demonstrating them. So say 20 years after there's an increase in smoking rates in men, they saw that lung cancer rates in the male population began to increase rapidly. Or 20 years after women began to smoke in large numbers, lung cancer also went up 20 years after. So studies in this case were longitudinal ecological studies in the sense that they used only national data on smoking and lung cancer rates, right? So they just saw, here's the number of people that are smoking, here's the number of people that have cancer at a particular period in time. And so it doesn't relate the individual cases of lung cancer to smoking in that situation. And so the task of establishing that causal relationship is done by using cohort in those case control studies. You guys remember what a case control study was? It's retrospective. We're basically starting with who has the outcome that we're looking at, and then we're taking people that don't have the outcome and matching them to those patients to determine, see what we can find, right? And cohort studies are going to be generally more of a kind of prospective thing where we're taking people who have risk factors and then going forward to see who develops an outcome. So kind of a reverse way of thinking for each one of those. So again, cohort is going to be a clearly defined group of people to be studied. In these studies, investigators begin by assembling one or more cohorts based on usually risk factors are going to be the thing that's going to be studied, so either those that were or not exposed. And then again, you're taking a random sample from the population. That's ideal to make sure that you're not going to have biased data in that situation. After the cohort of the study is selected, subjects are going to be followed over time to determine whether or not they develop the disease of interest. And then the risk factors that were measured at the beginning of the study predict the disease that's occurring. Right? So you're saying that, okay, these guys that smoked versus these guys that didn't, who developed lung cancer? That's basically what they're looking at in these cohorts. So the defining characteristic of cohort studies is that the groups are defined on the basis of exposure and are followed for outcomes, right? You're not taking a bunch of people and then seeing who develops the outcome and then looking for risk factors. That wouldn't be appropriate for these cohorts. So you really have to define those risk factors beforehand. Where, in contrast, the case control studies are going to be groups that are assembled based on the outcome status, and then you're queried for the exposure status earlier on. So again, those are mainly going to be retrospective. Cohorts or studies are generally going to be more prospective. And so, like I said, there are generally two types. You can't have cohort studies that are going to be retrospective, so I'll show you a picture here in just a second that'll kind of demonstrate that. So looking at the type of study here, and then looking at the time frame we're looking at. So again, for prospective cohort studies, this is where you're going to be assembling the cohort and collect data based on the risk factors, and then you're going to look to the future to see who develops those outcomes. If you were to have a retrospective cohort study, this is where you assemble cohorts by collecting historical data or risk factors, and then you kind of look forward in time to determine, at the present time, who has had the outcome of interest. So which one do you think which one of these do you think would have a little bit more statistical rigor, or to be more, you'd be more sure of the causal association that they would show? The prospective, right? Why? Okay, right. So I've kind of accounted for whatever risk factors I'm looking at, and then I'm looking for the outcomes in general. And so in this case, like, I'm doing all the data collection in these prospective studies, right? Or the investigators are. In this situation, in the retrospective, the data is already being collected. So imagine if you were dealing with, actually a really good example of this would be my coral snake research, right? So if you could say anything, you would probably say that it was more of a retrospective cohort study. Basically, I already had all the cases were done, and I basically were looking back and saying, okay, so these are the patients who had delayed administration of antivenom versus those who had early administration of antivenom, and looking forward. And so one of the big troubles that we had was that all this case information was being collated, and there was changes in the software over time. So initially, in the beginning stages of the software, this is back in like 1992, when they finally started entering in all these cases in the computer, it was all freehand. So in order to determine whether someone had an adverse effect or a specific clinical manifestation of a coral snake envenomation, you had to read through it and find it, right? As opposed to later on, say in the early 2000s, they had basically you'd have tick marks on the cases where you can click off. Okay, they had they had paresthesias, they had anaphylaxis, they had all these things, and so it's much easier to collect that data when it was not all free-handed, and so that made determine that information much more easy. But there was a chance to miss stuff in the earlier time frames. Right? So because I was not doing all the data collection for people as they're being envenomated and following them, there's room for bias to be entered in there, right? And so that's one of the things that they should be listing off in their discussion is that, hey, there could have been things that weren't reported or things that might have been left out of the case, because it's only as good as the person taking the data. And then looking at your case control study, notice that here you're going to be starting with the people who had the outcome, and then following it backwards to see what their risk factors were, right? So again, looking to see who has measles, and then going back to see who got vaccinated. So again, it's all going to be retrospective. All right, so it's prospective cohort study. So in the investigator is going to be assembling study groups in the present time, collects baseline data, and then continues to collect data for a period that can last many years, right? So obviously the amount of time this is going to take to perform these studies is much longer than these retrospective studies. And so several advantages of doing this would be that they're able to control and standardize the data collection as the study progresses, and can check the outcomes as they happen in real time. And then the estimates of risk obtained from prospective cohort studies are true. So you can look for things like absolute risk differences. You can do relative risks that are occurring because you're looking for new incidents of disease. And many different types of disease outcomes can be studied when you're doing this type of design. Cohort studies are going to have the disadvantages of that only the risk factors that are defined and measured at the beginning of the study can be used. So say you're looking for 10 years at cardiovascular death in patients who say have hyperlipidemia versus those that don't. You can't just add in another risk factor, say later on, and look retrospectively to see who had that in those cohorts. You really don't want to do that. You need to really a priori define all of your risk factors you're looking at, and then define your outcomes as well. Also going to be high cost to run these. You can have possible loss of study subjects to follow-up, so if people decide they don't want to participate, they can leave whenever they want. And then you have to wait a long time for the results to be obtained. So a very good example of this, have you guys heard of the Framingham Heart Study? Yeah, so it's probably one of the biggest prospective cohort studies done, beginning in the 1950s and still continues today, I believe. And so here in the next table, we show an 8-year risk of heart disease is calculated from those Framingham study questions, or the equations they had there. So for instance, they were looking at, say, what was your 8-year risk for cardiovascular disease in, say, a 45-year-old man. Those that had the lowest risk or had no, those that your baseline risk were here, say had about 2.2% versus those based on the risk factors that were defined at the beginning of the study. They would say, okay, what is their risk ratio or their change in risk based on having these risk factors, right? So your cohorts are people that had the risk factors versus that don't, and then looking at their cardiovascular disease development as time went on. Looking at retrospective cohort studies, so some of the time and cost limitations of the prospective cohort study can be mitigated by doing a retrospective cohort study. So in this approach, investigator goes back in the history to define their risk group. Say for instance, in this case, you're looking at people exposed to the Hiroshima atomic bomb in August 1945, and then you follow those group members up to the present to see what outcomes, either cancer or death, that occurred by then. So you're starting in the past with risk factors and then going up to the present time for outcomes. So many advantages of the prospective cohort study, including the ability to calculate absolute risk, but it lacks the ability to really monitor and control that data collection process, like I mentioned in the study that I did. So retrospective cohort study, say, was done in 1962, and they were investigating to look at prenatal X-ray exposure, which nowadays we know is a no-go. But in the past, the radiographs were used to measure the size of the pelvic outlet for pregnant women, and they were exposing their fetuses to X-rays in utero. And so they were identifying one group of subjects who had been exposed in utero and the other group who had not. So again, defining them based on the risk factors and retrospectively. And then determining how many subjects from each group had gotten cancer during childhood or in early adulthood, right? So that was up to the time where they started the study. And so they found that individuals end up having a risk ratio of 1.4. So they end up having a 40% increase in the risk of having cancer if they had been exposed to those X-rays. So based on that, we don't use X-rays for pregnant women, or at least put some lead on them. So, and then in the case control studies, this is where the investigators are going to be selecting a case group, so people who have the outcome of interest, and then you have your control group on the base of people who never had the outcome. And again, you're usually going to have multiple subjects as your controls to try to match to those cases. And then you look retrospectively to see what kind of risk factors they had and what was kind of being linked to those outcomes. And so again, if anything, you're really comparing the risk of having the risk factor of the two groups, is another way to say it, kind of another interesting way to say it. So here, the actual risk of the outcome cannot be determined from a case control study because the underlying population is really unknown. We don't really know what the full number of patients who had the risk factor to begin with. We only have the cases and the controls that we're really looking at. So here, remember, because we're only looking at prevalence and not incidence of new outcomes, we have to use odds ratios rather than using risk ratios, right? So again, cases and controls are going to be assembled and are questioned, or say relatives or medical records are consulted regarding the past exposure to risk factors. And so based on that, your time relationships in a case control study are similar to those in a cross-sectional study, where the investigators learn simultaneously about both the current disease state and any risk factors that might have existed in the past. And so because of that, you can't establish as good of a temporal relationship there. Case control studies are going to differ from cross-sectional studies in that the sample for the case control is chosen specifically from groups with and without the disease of interest. Okay, so again, when you're just doing cross-sectional study, you're just kind of looking at everyone and just saying what the prevalence is between the risk factor and the disease state. Whereas with the case controls, we can look at who has the cases, who doesn't have the outcome, and then look at their risk factors. So all the people with the disease of interest in a geographic area and a time period can be selected as cases, and this helps to reduce biases in the case selection. So the larger number of cases you can pull, the better off you are to reduce some of that bias. Case control studies are going to be especially useful when a study must be done quickly and inexpensively. So this is usually good for a lot of student research projects and things like that. And also useful if the disease is going to be relatively rare. So say it has like a prevalence in the population is less than 1%. It can be very difficult to find enough cases if I were to do, say I'm looking at a specific type of cancer, it's very rare, and I'm trying to look at risk factors that may lead to this cancer. If I were tried to do a prospective study looking at these different risk factors, I'd have to include a lot of patients to find even one person with that outcome. So being able to select my patients based on their outcomes already and then look for risk factors is going to be easier to do. So, for instance, if I was looking in this case, if the new cancer was found in 1 in 1,000 persons screened per year, then you'd have to study 50,000 people just to find 100 cases to show any kind of follow-up, right? So this is why a lot of these case control studies are done for these low prevalent type of diseases. So again, only one outcome really can be looked at, or one disease state, and then you can look at many risk factors based on that. So go back and look for any kind of different associations you can make from that information. So in general, case control studies are going to be better for generating hypotheses than they are for necessarily showing those causal relationships, because the temporal aspect is going to be difficult to show. Disadvantages to your case control studies are going to be that in determining the risk factors that have the potential for recall bias. So again, if you're interviewing patients or you're consulting medical records, if the information is not present or they don't recall it, then you can have a hard time getting that correct information. Or if they have the disease state, they may have too much recall bias and recall things that people who were controls may not remember. So you can maybe find some spurious observations there. So controls are usually going to be matched for individually to the cases based on age, sex, and often race. And you really should try to control for as many factors as you can. So say, for instance, you should be matching controls from the same diagnostic setting. So for instance, if you were looking at controls being taken from the same hospital that were examined for a disease with the same organ system, so say we're looking at pulmonary disease, presumably a similar work group or similar workup, including chest X-ray and spirometry, should be done for those asymptomatic cases to make sure that we were not having some detection bias, and make sure we weren't missing some outcomes based on that. So the better you can define those controls and make sure they're similar to your cases, the better. So, for instance, if we were looking at a study that was concerning birth defects, the control subject for each case might be the next infant who was born at the same hospital, of the same sex and race, and who had a mother of similar age and from the same town, right? So this way you're trying to control for as many confounders as you can to eliminate that bias that can be introduced there. Given the difficulties of selecting a control group with no bias, 2 or more control groups are often assembled, one of which is from the general population. So that we have another control group you can compare to try to make it a little bit more, make the results a little bit more generalizable, increase external validity so much. One thing you may do, though, if you are using matching, is what is called overmatching. And this could be a case where cases and controls were inadvertently matched on some characteristic that is potentially causal, and that cause would be missed. Right, so if I were to match them on the same thing like gender, and gender is actually one of the causal factors here, I'd be missing that. And so another example would be like in early studies of causes of lung cancer, cases and controls have been matched on smoking status that would not have been able to be found as a potential causal relationship. Right, so you need to keep those things in mind. Case control studies were used to help clarify the etiology, say like in the 1989 epidemic of eosinophilia myalgia syndrome. This is one of the cases where they were actually looking at a over-the-counter dietary supplement of L-tryptophan. It's timely. Most of you guys probably have some tryptophan left over from last Thursday, right? Maybe. Just see if you guys are still asleep from that or not. So 2 case control studies were done to test the hypothesis that the source was the supplements from this Showa Denka manufacturer, and to determine the odds that the source of the pills made the difference, right? So again, we're looking at odds because we're looking retrospectively for this case control study. And so if the source made no difference, you would find that the expected odds ratio would be 1. So depending on, it doesn't matter what source you're getting the supplement from, your odds are still, of developing the outcome is still 1. And so what they were able to do is they showed that from this one particular manufacturer, the odds were 57.5 times the odds of getting this eosinophilia myalgia syndrome than if you had received a different manufacturer. And then even if you did undertook a similar case control study, the odds were still 19.3 to 1 that you were more likely to develop this. So in both studies, the odds ratio showed a strong association with eosinophilia myalgia syndrome from this particular manufacturer, and so they were able to say recall that or stop distributing it. The sooner I get done with this, the sooner you guys can go study for HEMONC, right? Oh, you have another class after this. Won't want. I'll take the full time then. Okay. Any questions about the material from yesterday? Nothing at all. All right. So we're going to continue on talking about different study designs we might see in some common epidemiologic studies. So we were talking about cohort studies. We're talking about case control studies. And so one of the kind of the newer things we'll talk about are going to be a nested case control study. Have you guys ever heard of one of these before? Okay. So this is a relatively new study design, and basically what we're doing is taking a cohort study, which is again going to be taking, is that more often going to be a prospective or a retrospective type of study? Yeah, more frequently see a prospective kind of cohort study. And when I say cohort, what does that mean?
Same age or same demographic.
So, okay, so I'm having, say, two groups. What's the differentiator between those groups?
The independent variable.
Right, so think about, okay, when we're doing something like a case control study, remember that's going to be more retrospective when we're looking for people who had the outcome versus those that didn't. In these cases, when we're looking at epidemiology, we're either looking with these prospective cohort studies. The cohorts are basically divided up by either those that have a risk factor or those that don't, or if we're doing some sort of intervention, we might have the intervention group and say the control group. So think about the groups of people you're looking at. And so for this cohort studies, you can do kind of a prospective cohort study, and then from that, you can take that information, since you have all the data there, and say, well, it'd be a waste if I didn't use any of it, besides just the initial study that was done. And so you can kind of do some follow-up studies from that. And so basically what you're doing is you're taking this cohort study, which is done prospectively, and then you're taking that data at the end of it and doing a case control study from that. So essentially, you're going to be looking at patients who had an outcome that you're interested in that data set, and then finding controls for them within that same data set who did not have the outcome, and then looking back to see what risk factors were different between them. Okay, so basically, we're still doing the same matching, still the same process. You're just using all the people within that sample that you were pulling from that original cohort study. So, for example, we were looking at a nested design that was used in a study to evaluate a question about meningitis. And so basically what they were looking at was seeing whether or not there's an association between prior use of non-steroidal anti-inflammatory drugs and that frequency of non-bacterial meningitis. And so what they did was that the patients for the nested case control study were taken from a large prospective cohort study of patients admitted to the ED because of suspected meningitis. So again, the thing that they're looking at may not be directly linked back to what the original study was on, because we're going to be looking for some other type of risk factor, some other outcome that that study may not have been originally looking at, but the data was already collected for it. So basically using the patients from that cohort, a nested case control study was designed. And so in the study, the cases were those that were consisting of patients in whom a non-bacterial meningitis was diagnosed. So that was the outcome they were looking at. The controls were people in whom no meningitis was diagnosed, right? So those are controls because they didn't have the outcome. And then they went back and looked at the data to see who had received non-steroidal anti-inflammatory drugs to see if that was going to be associated with having a diagnosis of non-bacterial meningitis. That kind of makes sense how those work? So if you're thinking about kind of the conclusions you can draw from that, are those going to be as strong as if you had done a prospective cohort study? Why not? What do you think now? Yeah, so you're kind of using data that's already kind of been produced for you, right? So it's always going to have, you're always going to have stronger conclusions when you can do your own prospective study looking at a priori kind of question. And, this could be something where, I'm looking at this and I'm going to say, well, where can I find an association? Okay, well, it looks like non-steroidal drugs are a good one. Let me see if Tylenol produces an association. Let me see if aspirin produces, So potentially you can go through and kind of data mine these things to find something that fits whatever you're looking for. Ideally, you'd want to kind of have an a priori idea of what type of outcomes and risk factors you're looking at, but again, you're always going to have a better, stronger conclusion and better data if you did your own study on asking that question. Because again, this is still retrospective information we're acquiring now, and you'll see these being done frequently. Where a good example of this would be, I'm not trying to brag about any research I've done, but this is something that happened in my research. Listen, when you collect all these like coral snake cases, like no one else is ever going to do this, so you want to mine it for as much data as you can, right? So essentially one of the things we did, so I was looking at all these coral snake cases, we collected all this data about the different outcomes that happen with those patients, and so we were able to get a publication out of that. And so one other thing we were able to do is we submitted a poster to be presented at a conference, and basically what this one, it was an emergency medicine resident who needed a graduate project basically, and so he wanted to look back at the data to see what were the predictors for patients who had a coral snake bite who were intubated, what were signs and symptoms that were predicting that they would need to be intubated, right? So we're looking for things that patients who are intubated versus those that weren't. So kind of doing a type of case control study and going back and seeing, okay, well, what do they have? Were they having paresthesias? Were they having bulbar paralysis? What were the things that were kind of making them predisposed to needing to be intubated? And so that was a good example of kind of a nested type of study we did with data we already had lying around, basically. And so we had my study went 1 year, and then they basically did that one for the next year, and so get a little bit more publications out of it. But again, not going to be as strong of a conclusion as you can draw because the data was already lying around. We could have changed it to whatever we wanted to find an association. That one just happened to work for us. So, and again, this is also going to be much more simple and easy to do because all the data is already there. All right. So a variant of the nested case control study is going to be one known as a case cohort study. So the study would also begin with a cohort study that was already existing, and the controls for the study are going to be taken from that same cohort. They are going to be identified before any of the cases develop. So although some of the cases may already be existing there, but you're basically trying to do within the cohort study, basically another type of cohort study there. Analysis gets a lot more complex, and they're not done very frequently, but just be aware that they exist. All right, so again, this is looking at some of that information we were looking at when looking at the L-tryptophan. I remember we talked about that example yesterday. We were looking at the different manufacturers and the odds ratios of them having that eosinophilia myalgia syndrome that had popped up there. Just notice that when we're doing these, because these are looking at retrospective data, we're doing these case control studies. Notice that we're not doing a risk ratio, because again, we're not looking at new incidence of cases, we're doing those odds ratios. And you see how these are kind of being calculated here, where how would you calculate the odds that patients who have this L-tryptophan, this brand, how would you figure out the odds of them developing this condition? Remember how that's calculated. So basically, you're going to take all the cases that occurred over where situations where the case did not occur. So basically, in this situation, you'd have 45 divided by 18, because you're looking at the odds of someone who received this brand of L-tryptophan developing this syndrome, right? Whereas if I was looking at the risk of it occurring, say they did a prospective study, it would end up being the number of cases divided by the total number of people who were at risk for developing this. So in this situation, if I were to do a risk ratio for if it was a prospective type of study, I would end up doing 45 divided by 45 plus 18. Whatever happens to be. So basically, when you get those odds developed, then you can do the odds ratio, where basically you're just dividing one set of odds by the other, and so you end up getting this case here where it was 57.5 times more likely for those patients to develop that than those that received a different brand. Okay, so what are some experimental designs for actually testing hypotheses? So two of the big ones you're going to see, one of which we've already been alluding to pretty frequently, are going to be randomized controlled clinical trials. Otherwise, you would typically see like RCTs, and then a randomized control field trial, which is a little bit different, but we'll talk about how those kind of compare and contrast them a little bit. Both designs are going to follow the same series of steps and have many of the same advantages and disadvantages. It's just looking at what type of intervention you're going to be implementing here. And so the major difference between the two is that clinical trials are usually going to be used to test therapeutic interventions, like if I'm trying a new drug out, if I'm trying a new type of surgery, in ill patients. And that field trials are usually done in more of preventative interventions for persons in the community who are already healthy. So, for instance, if I was doing like a smoking cessation or trying to prevent smoking from starting in, say, school-age children, that would be more of like a field trial that I'd be implementing, looking at patients who are not already smoking and how can I prevent that from occurring in the first place, right? So again, these are all going to be prospective studies. So you are going to start off by recruiting your study participants. You're going to randomize those groups, because if we don't randomize, what can we expect to have occur? Bias, exactly, right? Because you don't want people to say, well, which group would you like to be in? Would you like to receive placebo for this deadly disease you have, or would you like to receive experimental drug? That's kind of a loaded question, right? So you don't want to do that. So you want to randomize to make sure that they don't know which one they're going to be getting. And then you measure your baseline, whatever it happens to be, and then either have them have the intervention or have the control or placebo, or however you're controlling that experiment, and then measuring the outcomes. So again, all prospective in nature. So in a randomized controlled trial, often referred to simply as an RCT, the patients are enrolled in the study and randomly assigned to one of the groups, right? So either intervention or control group. And these are really going to be the gold standard for studying interventions because of the ability that we can minimize bias in the information obtained from the study subjects. Again, we're collecting all of the data. You can start to establish things like temporal relationships, like if I'm looking at say, giving one type of drug to a patient versus placebo and seeing which ones cause cancer. Like, you're going to be able to detect those sort of things in a temporal type of manner. Obviously, you cannot completely eliminate bias. That's going to be impossible in any study, but you can try to do your best. And we'll see some challenges and ethical dilemmas for investigators that can come about from this. So what are some potential ethical dilemmas you could see with doing randomized controlled trials? What type of patients can you not do some of these trials in? Kids? Okay, so why kids? Yeah, so they can't really consent, right, because they're not adults, right? So you have to have their parents consent for them. And who else did you mention? Pregnant women, right, because you worry about dangers to the fetus and things like that. So again, these are kind of considered to be protected groups. And so you guys ever heard of the internet or the IRB? Basically, it's the I think it's the International Review Board, but institutional. Thank you so much. I couldn't think of that word. Institutional Review Board. What is the Institutional Review Board?
Each institution, or you can get a private one that's just their thing, will look over a study and point out where you're creating ethics violations.
Mm-hmm. Yeah, so essentially it's trying to make sure that the study you're doing is not going to create any kind of ethical violations. And so when you mention kids, pregnant women, prisoners, things like that, those are protected groups because they are potentially more at risk than you would say for just a regular healthy person, right? Obviously with pregnant women due to danger to the fetus, for kids because they can't really consent, they don't really understand what type of experiment you might be doing that they would potentially be objectionable to, and then prisoners because they're kind of like captive audience quite literally, so you don't want to do that. So IRBs are really good to make sure they're reviewing studies to make sure that you can perform them without having any ethical violations. They're usually made up of both medical professionals, lay people, and there's a couple other requirements they have for making sure that they have kind of all facets being looked at. And so every institution that does research should have an IRB that is pretty active in reviewing that stuff. Even me, when I did my study, even though we were looking at retrospective data, we still went through the IRB process just to make sure we weren't going to have any issues with, say, HIPAA or things like that could possibly pose problems. So IRBs are definitely a good thing to know about. So anyway, so again, these are going to be, RCTs are going to be much more rigorously looked at because again, you are either giving drug or say placebo to somebody, and that's important. So for instance, when we are doing some of the studies over at Nemours and we have those spinal muscular atrophy kids and we're giving them intrathecal medications and either giving them sham drug or basically just saline versus actual drug, someone has to review that to make sure that we're not being mad scientists and just kind of giving little kids drugs at random, right? So we make sure we have actual sound protocols for that sort of stuff in place. So to be enrolled in an RCT, the patients must agree to participate without knowing whether they will be given the experimental or non-experimental treatment, right? So this would be a single blind where they're not really sure what they're getting. But again, informed consent is going to be a huge part of this to make sure that they know what they're getting into, and also to know that they can take themselves out at any point, right? Because you never want to force someone to be in these studies. Major ethics violation. If possible, the observers who collect the data also should be prevented from knowing the type of treatment each patient is getting, so a double-blind study in that case. Some cases you'll find there will be a single-blind study, but double-blind provides you a little bit more security in preventing some of that bias from the researchers potentially knowing what the patients are getting. Because again, if you're doing subjective measurements of things like, say you're looking at gait or something that where you could have intra-observer type of variations there. If you knew that they were getting drug versus not, that may skew you towards thinking they're doing a little bit better or worse. So double blinding is always going to be a good thing. And this is needed to equalize that placebo effect as we've kind of alluded to. So for true blinding, the non-experimental treatment must appear identical to the experimental treatment. So very frequently the pills or the capsules or whatever happens to be is going to look exactly the same. Like I mentioned for that intrathecal study, basically, especially with some of your older patients who are kind of aware of what's going on, the people getting the actual drug would get the lumbar puncture, and the other ones in some kids, I actually think they were actually injecting saline, but in some of the arms of the study, they were actually just kind of numbing the area and then just basically doing a pinprick. So that way the patient didn't really know what they were being exposed to, right? Obviously, like for babies and stuff like that, you wouldn't necessarily need to know that because they couldn't really communicate with their parents as to what happened. But anywho, a good example of this would be a pill packet in the next slide here where they were looking at 2 preventative measures. They're looking at aspirin and beta-carotene in that physician's health study. So you can see here they look identical. You would have no idea whether you're receiving active drug or placebo in these circumstances. This is done very, very frequently just to make sure that patients have really no idea what they're receiving, and hopefully the investigators would not know either. Really only the researchers would have access to that randomization and would know what people are getting.
So we're looking at both right now. Some of those are placebo and some of those are active?
It depends on what the patients had been prescribed or had been randomized to, right? So this could be all sham drug. It could be active drug. They may have done something where they were doing, say, some people were getting placebo aspirin and actual beta carotene, or vice versa. I'm not sure the actual study protocol, but this would just be one example how it might be done. Yep. I always when I first started doing some of the research stuff, I always felt I had the secret nuclear launch codes or something, because they're like, you have to protect this. You can't break the blinding, because otherwise the whole study's going to go out the window. And so you're just like, I can't tell anyone. I have a secret. And so that made me want to tell people, and it was bad. I had to. Never broke the blinding, fortunately. Okay, so it's usually going to be impossible or unethical to have patients participate blindly in the study involving surgical intervention, because the blinding would really require a sham operation. So these are tougher to do, and you're going to see very frequently that those are not going to be super easy to perform in a lot of cases. So if you're looking at non-surgical interventions, though, it's going to oftentimes be a lot easier to get an effective placebo. So very frequently, if it's like a liquid you're taking, it's going to look exactly the same, has to be the same viscosity as what the actual active drug would be, or whatever it happens to be. It shouldn't look identical. And again, it would be unethical if the intervention were strongly believed to be the best available, whether or not it's been established scientifically. So we were kind of alluding to in the biostats section, we were talking about giving zidovudine or AZT to these asymptomatic HIV patients versus placebo. So nowadays, could you do that study?
No.
Why not?
Because you know that it works.
Right, we know we need to give drug to patients with HIV to make sure they don't progress. But at the time, we didn't know that, so it was okay to do it, right? Because who knows, maybe the drug would have caused them to progress even more quickly. So, as the medical literature kind of matures, you're going to find that certain studies that you might have been able to do 10 years ago, you can't do nowadays. Lobotomies aren't really a popular one to do anymore. I tried doing a few to my students, but they wouldn't buy. So, anyway, so again, that's why you're never going to find like an RCT where you're comparing like prenatal care versus no prenatal care, right? Because that would just be unethical. Even though we may not have the actual scientific data to say that no prenatal care is going to be disadvantageous to those fetuses, common sense tells you it's probably more care is better. Or at least some care. So again, bias is possible through some biases that have been minimized by the randomization process. You also can minimize it in the fact that it's a prospective design, and hopefully by the double blinding. The two groups being compared, there may be different rates at which patients drop out of the study or become lost to follow-up. So what are some reasons you think patients might drop out of these studies?
Side effects.
Okay, so good. So side effects might be one. So that might be leading them to think that, okay, I'm feeling even worse. I don't want to be taking this drug anymore. I'm gonna drop out. What are some other reasons you might drop out?
They're not getting treatment for whatever it is that's wrong with them.
Well, they don't know if they're getting treatment or not.
But if they're not getting better, they're not
Okay.
experiencing relief.
Exactly. So if
They're
you,
out of the study.
yep. So if you think, okay, if I'm not feeling any better, I'm not getting any better, I'm just going to drop out, right? Which can be important for some drugs. If you think about things like antidepressants that take like up to 6 to 8 weeks to work, people might be dropping out too early because they're not feeling any better, right? So that could definitely be another reason why someone might drop out of a study. So therapy changes and dropouts are going to be special problems that involve, especially severe disease such as advanced cancer. If people feel like, hey, this isn't really working, I'd rather just have better quality of life for the short period of time I have. Things like that may lead them to drop out. And then if, obviously, we mentioned the side effect thing. Even though treatment may be effective, it could just make it really just intolerable for them. So I'd rather just be sick than have this drug. So again, another good example of this would be something like an antihypertensive trial. We know a common side effect there is going to be erectile dysfunction. So it may not be really driving with your patient's quality of life, so they may decide to drop out. There's also this idea of publication bias. Did anyone watch that John Oliver video that I put on the thing? So what is publication bias?
Yeah, no one wants to waste their time publishing negative results.
Exactly. So a lot of people, so obviously when you're a big journal, it's still a business just like anything else, and so you want to publish things that are going to get read. So if I say, okay, I gave these 2 different treatments and I found no difference, is that super exciting? No, it could be. It could be if you're like, if you're trying to disprove that, statins are really good for patients with cardiovascular disease, and I was able to show that, through a really well-designed study with, 10,000 patients that did nothing, that might be newsworthy, right? But in a lot of cases, people don't want to publish negative results, right? So, and we know that one of the cornerstones of science is that you reproduce the results that you have achieved. And again, doing something that someone else has already done isn't that exciting either. So a lot of times we don't have replication of a lot of studies. Things that are negative don't get published, and so we run into a lot of issues with this. And so this is also a big problem, especially in the pharmaceutical world, especially when new drugs are trying to be pushed out. They do randomized controlled trials for all those things, but you'll see that a lot of those studies, especially the ones with negative reviews or negative results, may not actually end up getting published because of that. So just be aware of that the things that you're finding in the journal were selected for possibly some reason, and so there's many other articles that may have been rejected, might have been showing the exact opposite effect of what you were reading in that particular article. So just think about that. All right. So in an attempt to reduce a publication bias, a group of editors created a policy here. And so basically what they were saying is that, if the journals were going to be considering publication of only results of RCTs, they had to be registered with a clinical trial registry. And so again, this was, they have to register the trial before the actual patient enrollment occurs. And so if you do this, it at least gives you a little bit more credence, saying that, hey, we want to do this study, we're going to go ahead and register it. And that way it gives the publications a little bit better idea of, okay, we should adhere to these standards. Even if the results are negative, we should go ahead and try publishing this. One of the big trial enrollment sites you might come across is called clinicaltrials.gov. Has anyone ever been to that website?
Yeah, it's really hard to use.
Sometimes it's hard to use. Very frequently, though, if you're looking for a specific thing, so if I wanted to find, say, trials that are looking at N-acetylcysteine and acetaminophen overdose, I could try typing in acetaminophen overdose, I could try typing in N-acetylcysteine, whatever it happens to be, and hopefully you should be able to pull up a lot of trials that may be involving that. So there may be no trials for the thing you're interested in, or there may be a ton, depending on what it is. But that's a good site to go and find if there are any trials. It's a good place as well for patients if they'd like to be enrolled in a study. You may be able to find studies that have open enrollment that may be able to get a patient involved in. A good example from the tox world is, has everyone ever heard of the death cap mushrooms? It's the Amanita phalloides. It's a very dangerous type of mushroom that causes hepatic failure. And one of the potential antidotes we can use for is a version of milk thistle. There's a pharmaceutical product for this, but because the rarity of someone actually coming down with a Amanita mushroom poisoning, there's not a lot of patients being treated with it. And so they actually have a thing where if you know your patient has ingested these mushrooms and you think they're becoming toxic, you can actually find this study, call them up and say, hey, I'd like to enroll my patient in this, and they'll actually mail you out the drug and have to go through all the paperwork and stuff like that. But that would be a drug that has kind of an open rolling enrollment to allow more patients to get in there, right? Because there just wouldn't be a ton of them otherwise.
How quickly fatal is this death cap mushroom?
It can take anywhere between 48, 72 hours before it really kind of manifests itself. It's not a quick, painless death. It is pretty miserable for the most part. Massive or multi-organ failure and
But you have time to enroll in a study and wait for the
potentially, yeah. So I mean, you could have 12, 24 hours because it's kind of like Tylenol poisoning, where like they don't really manifest until 24, 36 hours after the actual ingestion. We'll talk more about that when we get to a tox section in Pharm 2, but otherwise I could talk about that for the next 2 hours. Anywho, so again, the requirement in this case would be to force all trials to be registered before they began. That way, if they had a hope to publish in a major medical journal like JAMA, New England Journal of Medicine, things like that, they would need to be registered beforehand to make sure that these are kind of legit trials, not just something you ran through a Craigslist ad or something like that. So again, that way the investigators could also explore, what would happen if what had happened in the studies that did not end up getting published. You can kind of go back and look at those results as well. So field trial, like we mentioned, is going to be similar to an RCT, except that this is normally kind of going to be an intervention that is preventative rather than therapeutic. So trying to prevent healthy people from getting sick versus treating sick people. Usually going to be done in the community, and the appropriate subjects are randomly allocated to receive either the preventative measure or the placebo, and then followed over time to determine the rate of disease in each group. So can you guys think of any examples other than the one I mentioned? Necessary. So if you think about, I'll think a lot of public education kind of interventions, because again, we mentioned that behavioral changes are usually the easiest and can potentially have the most impact, right? So if I get people to stop smoking, I can probably dramatically reduce the amount of lung cancer out there, right? So those are the kind of things they might be looking at. So you imagine things like, if you did a study looking at patients who either went through the DARE program or students who didn't, comparing the IV drug abuse rate in each group, right? So that could be potentially a study you could do to look to see the effectiveness of this intervention here. So very frequently you need the control might not be like a placebo like you would think in a randomized controlled trial, but it should be something that is either a standard, whatever the standard of care is, or the standard of education, or whatever it happens to be, versus your new intervention.
Is it always preventative? Like, if you're looking at somebody who goes through AA versus somebody who tries to quit drinking on their own, would that be randomized controlled or field?
That gets a little bit more murky. You could probably call it a field trial, especially if you're doing amongst a community type of effort, right? So if you had a large group of people out in the community you were trying to do this intervention on, that probably would be more like a field trial. But you can kind of think of them there's not a lot of distinction made between these two. We just mention it here just for the definition's sake. So some other examples. So one would be vaccines to prevent paralytic poliomyelitis. We talked about that pretty much ad nauseum. Looking at administration of a 6-month course of isoniazid for tuberculin skin test converters to prevent reactivation. So again, these are things to prevent new issues from occurring, hopefully. Aspirin to reduce cardiovascular disease. So those will all be good examples of that. One disadvantage is that the results may take a long time to obtain. So again, if you're looking at the new cardiac events that are occurring after giving aspirin, how long do you think that trial might have to take? Like 6 months?
Probably years.
Yeah, years, like 5, 10 years, 20 years, because people are may take a long time. There's kind of latent type of or indolent diseases that take a long time to manifest. So again, these are going to be a lot longer and potentially a lot more costly in order to run. For example, the physician's health study that we mentioned, the aspirin arm began in 1982 and had results after 7 years. So again, these could take a while. Another disadvantage of these has to do with the external validity. So we've mentioned this already, but the ability to generalize those findings to other groups in the population. So if you have very, very strict inclusion-exclusion criteria and you're looking at a very narrow sample of patients, you're not going to be able to really generalize that out to a large number of patients. So again, if you're looking at something like the Framingham Heart Study, where was that done at? Yeah, so Framingham, Massachusetts. So again, you're looking at patients who are in the northeast of the United States, or is that going to be generalizable to everyone in the U.S.? Maybe. I mean, you may be able to draw some similarities there. They're not going to be one-to-one necessarily, but could I necessarily extrapolate that information to someone who's in Thailand?
No, diet's different.
Yeah, diet's different. Medical care is totally different. So again, you can see how the generalizability can change based on the type of patient you're looking at. So after study subjects for a randomized trial have been assembled and the study's exclusion criteria applied, it may be unclear which population that the trial may actually represent. So again, just go back and look at those inclusion-exclusion criteria. And again, it might make it hard to tell who might benefit from this intervention that's being tested. So again, if I'm looking at, say, this is done very frequently in pediatrics, because we mentioned that there's a lot of ethical issues with doing trials in kids, is that a lot of times we're extrapolating adult data back to children. Right, and so there's lots of inherent issues with that because you have to take everything with a grain of salt, because as we know, children are not little adults. They're going to do things differently. They have much different biochemistry, and so just because we see that giving this type of drug prevents X, Y, and Z in an adult doesn't mean it's going to do that the same way in a child. So, but unfortunately, if you don't have a lot of data, you got to do what you got to do, and sometimes you'll try to extrapolate as much as you can. So. Not formal epidemiologic research designs, but are important, are going to be some of these data summary, cost effectiveness analysis, and post-approval surveillance. These are kind of some miscellaneous study designs you might see with epidemiology. We've kind of mentioned these before, but a meta-analysis, what is that?
You take all the studies that have been done, try to see if they're rigorous enough, and then pool the data together.
Yeah, exactly. So a meta-analysis is going to be basically we're pooling all the available literature together to see if we can get to a consensus on a clinical question. We talked about the Cochrane review database. This is a very good one that you'll very frequently see, especially if you're doing research projects where you're looking to see, do statins reduce cardiovascular disease? There's probably a Cochrane review that's out there. They've looked at all the different studies to try to compare them and see what kind of results they can take. They can be very, very useful. Or they can be kind of useless in some cases. So one of the things we'll talk about when looking at the different studies is going to be their heterogeneity, which is a very fancy word. But what do you think the term heterogeneity means?
A good mix of subjects.
Basically means how different the different studies are from one another. So you want to have studies that were, in order to really take all that data to coalesce it, you'd like to be looking at very similar types of patients, to be able to look at very similar types of interventions. But if you have very different or disparate studies, it may be harder to coalesce that data into something that's actually usable. So there's a lot of heterogeneity. You can run into some problems there. So you can also see that there will be decision analysis and cost-effective analysis that are used to summarize data and can inform either certain clinical policy decisions, can look at how we're going to prioritize or what type of interventions we're going to do out there in the community. And we'll talk about all three of these a little bit more in depth in a later lecture. So among the most important uses for summary techniques that have been developed is going to be some of these recommendations for clinical preventative services, and there's some U.S. groups that take care of this. And these task forces are used, basically use a hierarchy for the quality of evidence that's out there. And so you very frequently will see this being mentioned in a lot of guidelines, especially if you're looking at, say, like the CHEST guidelines for anticoagulation, or if you look at the hypertension guidelines, they're going to list out the hierarchy of evidence here to say like which one provides the most evidence that such and such treatment is effective, or that this will prevent some sort of outcome. And so if you had to think, what do you think would be like the top highest level strength of evidence? What type of study? Yeah, so you see like randomized controlled trial is going to be the king here, right? Because you can have the least amount of bias. You're actually doing an intervention to see what's happening. And so this is going to have the best strength of evidence behind it. You'll see that as you start going down from there, you're going to be seeing even kind of weaker and weaker evidence associated with some sort of intervention. So, for instance, if you're looking at, say, 2A, or 2.1, notice how it's kind of broken down into different categories. You can see here that, okay, well, evidence is obtained from well-designed controlled trials without randomization. Okay, so we know that can include some bias. You notice that the bias is going to increase as you kind of go down the ranking here, where with a 2.2, the evidence obtained from a well-designed cohort or case control analytics study, preferably more than one center or research group. So what do you think that means, like one center or research group? So frequently you'll see a lot of like very large studies that are being done in multiple centers. So like if you're looking at, say, an intervention of statins on cardiovascular disease, you may see that this is being done in, say, 10 different hospitals or 10 different clinical centers in order to run this intervention. And so, for instance, when I mentioned that study we were running on looking at the pit viper antivenom, that was a multi-center study as well, where not just Shands Jacksonville was doing the study, but also all across, say, the south of the U.S. was running this as well, because that's where I have a lot of pit viper envenomations. We're also running this. So different hospitals are getting involved, and that will allow you to collect information on different types of patients by doing that. So again, the more studies or the more centers you have involved, the more kind of the strength you can apply to that information. And then just kind of goes down from there. Notice that the weakest level of information is going to be opinions of respected authorities based on clinical experience, descriptive studies, case reports, reports of executive expert committees. Why do you think this one's the weakest level of evidence?
An opinion. It's just an opinion of somebody.
Right. So if just because you wouldn't want to tell your patient, well, I'm going to go ahead and give you this drug because it's good for your hypertension. They're going to go, well, what level of evidence do you have for this? And you're like, well, my farm teacher told me it was good. That's just my opinion, right? You want to have guidelines to actually back you up. You want to have strong levels of evidence, randomized controlled trials to say that, yes, this is a correct intervention. Certainly, you're going to find there's no shortage of opinions out there. Clinical toxicology is rampant with it. If you ever want to have know what to do with the patient, tox patient, just ask 10 different toxicologists. You have 10 different answers, right? Because again, it is not ethical to do tox studies in patients or randomized controlled trials, because I can't give one group of people a heaping load of lithium and then dialyze them and give another group of people a whole bunch of lithium and not do anything, right? probably unethical. I've wanted to do it to some of my students, but besides that, yeah, it's not ethical. So a lot of times we're relying on things like case series, case reports, case control studies, things like that to try to get some information. It's never going to be as good as a randomized controlled trial. So very frequently, dialysis is like a huge area of controversy because it's not frequent that we need to dialyze a lot of these patients for different poisonings, and so very frequently it comes back down to kind of consensus opinion. And so they've actually had like a new working group, basically, where you get all these different nephrologists and toxicologists together to try to determine by looking at the evidence what they think is when you should dialyze certain people for different poisonings. So lithium being a good one. And so they try to come up with an expert opinion, but at the end of the day, it's not that strong of an evidence. It's still just expert opinion working on usually anecdotal information. So just be aware of the different levels of evidence that are out there. So other ways that we can do surveillance, the usual U.S. Food and Drug Administration drug approvals are going to be based on randomized controlled trials. We talked about the different phases of drug approval cycle. We were talking about the different size trials they're doing at the different phases. Certainly that the phase 4 trial is going to be when? Yeah, so drug approval after we're giving it to millions and millions of people across the U.S. So these are going to be increasingly important as time goes on. We found many examples where drugs are just removed off the market because you may have a 1 in a million side effect, but you're never going to find those until you give it to millions of people, right? And very frequently, the studies you're doing in, say, phase 3 trials may only be several thousand people who are receiving the drugs. It's hard to find those things. And so one good example of this, has anyone heard of Vioxx or Rofecoxib? What's going on down there? So Vioxx was a drug. It was a COX-2 selective anti-inflammatory drug that was being marketed for people who had, say, gastrointestinal issues and had chronic pain. And so we were giving those to people and ended up finding increased risk of cardiovascular death. So they found that was statistically significant. They found this temporal relationship and found there was a causal relationship, and so they were able to remove it from the market. And that was all related to this post-marketing surveillance they were doing, where adverse effects get reported up through the proper channels, either through the drug company or through the FDA. They get reported, and they can look at that data and see what's going on. So. Okay, so again, looking at the summary of different clinical trials, so we know that they're attempting to answer questions with valid data, and epidemiologic research is usually going to be looking at the state of health, disease, or risk factors, and then they develop hypotheses about these causes of illness and try to find preventative or curative interventions, and then they have to test them, right? So it's important to know that the types of studies are going to be better for generating hypotheses, and ones that are going to be better for testing it specifically. So we talked about the different types, so whether it's a cross-sectional, whether it's ecological study, those are going to be better for testing or generating hypotheses. Yeah, generating, right? Because I'm just taking a cross-sectional period of time. I'm just saying, okay, well, let's look at the number of people with lung cancer and the number of people who are smoking, right? I haven't established any kind of causal relationship there with that kind of data. So I need to generate a hypothesis from that and then test it with some other type of study. Again, for cohort studies, one group is going to consist of people who are exposed to a risk factor versus one who is not exposed to a risk factor, and then you're looking for outcomes, right? If I was doing a case control study, it would be different, where I'm looking at the outcomes and then tracing it back to see what risk factors those patients had. Yes?
What's the case cohort then? Is that prospective or retrospective?
The case cohort is going to be one that's one of those kind of nested trials, right? So it's one of those things where it's going to be more prospective, where you're looking at patients who are already within a cohort study to see who has developed an outcome. So those are pretty rare, and you have to do really complex analytics on that to determine anything. I've not really seen many that have been published before, but I may not be looking at the right type of literature, so who knows? Let's see. So again, like I mentioned with the case control studies, those are mainly going to be more retrospective, looking for risk factors in people who had the outcomes versus their controls. And so it may enable some hypotheses to be tested quickly and cheaply, but again, that level of evidence is not going to be as good as if you were to do a prospective either cohort or randomized controlled trial. Obviously, for testing hypotheses, the best ones are going to be RCTs or these field trials. We talked about the major differences between those. Any questions on this section? Yes?
Can you explain what the nested case control is? I don't understand the difference between the case cohort and then the nested.
Yep. Basically, if you were to run a cohort study, right? So say I was going to look at, in this case, if the example is patients who report to the emergency department and they were seeing who was being diagnosed with bacterial meningitis, right? So patients who say were reporting to the emergency department for certain symptoms versus not having the symptoms and who got diagnosed, say. So the nested case control study would be looking, after you did the whole study, when you're at the end of it, you would say, okay, well, I want to look at patients who had either non-bacterial meningitis or had no diagnosis of meningitis, right? So I'm looking for an outcome, right? And so then once I have my patients, I have my cases and my controls, I'm going to look backwards to see what risk factors they had. So I'm going to see, okay, well, who was using non-steroidal anti-inflammatory drugs? Maybe the non-bacterial meningitis had a higher proportion of people using non-steroidal drugs, and maybe that's statistically significant, right? So that would be a nested case control. The case cohort one is a little bit more complicated because you are looking, you have your cohort study that's already running, right? And then you're going to start this new cohort study within that where you're looking at different risk factors. It may be different from what the original study is doing, but you're asking a different question, right? So you have all this data here, you have all this information you're collecting on patients, but you're looking at something that's slightly different, and then running that forward, and then looking at new cases they pop up from there, right? So it's still kind of prospective, but it's just a little bit different than what that initial study was being done. And again, more complicated. It's not something that gets done very frequently because it's usually more difficult to do. Nested case control is really easy because the data is already there. You just have to take the outcome you're looking for and just look backwards. Any other questions on that? Okay.